Hello, everyone. My name is Judy Kim. I'm a professor at UT Southwestern Medical Center in Dallas, Texas. I want to welcome everyone to this two-part mini-series on new retina radio called The Good, the Bad, and the Frustrating. I have three wonderful guests with me today. Dr. Sunir Garg from Wills Eye Hospital in Philadelphia.
Hi, Judy. Thanks for having me.
And next, Deepak Sambhara from Eye Clinic of Wisconsin in Wausau, Wisconsin.
Thanks for having me, Judy.
And finally, Dr. Rishi Singh from Cleveland Clinic, Martin North and South Hospitals in Stuart, Florida.
Thanks, Judy, for having us.
Thank you all for joining. We now have two agents, two complement inhibitors for treating geographic atrophy from age-related macular degeneration. Sunir, let me start with you. How do you decide which agent to pick when you decide to treat patient with GA?
So we're lucky we have two agents. I use both of them, and I've had more experience with pegcetacoplan. I was PI in the study, so I've had familiarity there. And I think one of the things that's been nice about this space is there's been ongoing outcomes data from the pegcetacoplan studies, whether it's the Gale extension data, now we have 48 months of treatment, as well as the microperimetry data and the OCT data, has all kind of helped round out the picture of treatment. And so I'll often use that first, but I'll use both. And we're very fortunate that we have two. I have one patient who I had wanted to use Izervayon first, but the insurance company said, nope, you have to start with pegcetacoplan first, so I'm happy to do that as well. So some of it's dictated by the insurance companies.
How about you, Rishi? One agent is on label for every month use, the other is for every other month. Does it make a difference? How do you make a decision?
Yeah, first and foremost, we inherit some patients from the north, from Philadelphia and from New York and the tri-state area. So a lot of them come down to my area, and they're sometimes already on therapy. So I don't tend to switch them off of their current drug from where they've been assigned to. I keep the drug going while they're in Florida. If I'm initiating a patient on therapy, I give them both options. I talk about the options. I think the differences are frequency. I think the differences are IOI rates in the drugs and the studies, and have them make an informed decision based upon that. Sometimes there's an insurance dictation point where the insurance may dictate one or the other drug, but typically they don't dictate it, and I can choose and have that conversation. And I hand them materials. I don't actually initiate the therapy on the first visit. Sometimes I just give them materials, have them come back in 4 to 6 weeks, then have another informed discussion about it. I think it's a big step. I think at this point we know that these therapies are, first of all, not immediately needed to be given. We don't need to give them within, a month. But certainly we need to have a conversation where the patient understands the risks.
Yeah, now that I'm down in Dallas, I also inherit a lot of patients, back and forth between North and South, and I also do not switch. Deepak, Rishi mentioned potential IOI risk. Does that come into play as to which drug you want to use?
I certainly consider it, and I have discussions with patients about what the options that exist in our armamentarium. It's one of these things where you want to weigh what clinical trial data tends to suggest, robustness of data to help support your decision, but also the risks that we've seen with real-world use with some of these medicines. I think when I look at a patient, if they are monocular, I certainly have my own recommendation that I'm willing to give to a patient. When a patient's presenting, it really depends on the status of the fellow eye to help motivate a decision on one agent versus another. And so outside of those specific circumstances, I'm much like Rishi and Sunir in terms of starting agents and not switching people who might be inherited on therapy already.
We'll take a quick break and we'll be right back. Sunir, who are ideal candidates for this treatments?
That number for me keeps changing. And so initially when the drugs came out, I was treating people who were bad vision in one eye and I knew were going bad in the other eye. But I've come to realize that those patients probably are going to get bad and lose their central acuity no matter what I do. So I'm treating patients earlier. As Rishi indicated, I don't treat them on the first visit. I want to make sure that their disease is progressing. And I do that with OCT, autofluorescence, what have you. Because some patients, they don't budge very much. And I want to know that I'm going to move their needle. And then if patients still have good central acuity, I'm treating those people. And I'm treating them earlier than I was before. many of these folks, it's a relentlessly progressive disease. And we can't stop it and we can't undo the damage. So I think protecting tissue really becomes kind of important. When you look at the Oaks and Derby study and the patients who went over to the Gale Extension study, patients who had 4 years of treatment versus those who started treatment in month 25, there was a big opportunity lost in terms of the amount of tissue that was able to be preserved. And that data to me has been quite compelling and making me rethink which patients I'm treating and when I'm starting.
So there has been a lot of discussion in the podiums saying, pick a patient with one bad eye and one good eye, test the drug on the bad eye first, and wait a month or two. If they have no IOI, then give it to the good eye. I mean, is that passé now, or what do you do?
I think that's an important consideration. The ASRS REST Committee has done a great job educating us about this. It seems like those cases of IOI were after the first exposure to the drug. And although they quote a 1 in 4,000 rate, the eyes that really lost a lot of vision, it was about a 1 in 8,000 rate, which is not a trivial rate, but in the context of the risk of the injection, it's not, really unreasonable. But if I had a choice where patients had one bad eye, I would start treatment in the bad eye, reassess them after 3 to 4 weeks, because that seems to be when the incidence sort of passes. And if there's no inflammation in that eye, I'm quite comfortable in treating the better seeing eye. But if a patient had 2 good seeing eyes with GA who would otherwise meet the criteria and benefit from the drug, I don't hesitate to treat them. There's an idea of treating the first dose as a half dose. There's some thought that the inflammatory reaction is from the pegylation. And there's a thought that if I have less antigen, maybe I'm going to have less of an antigen response. Although I don't have data that that's helpful, I do that and it helps me sleep better at night, if nothing else.
And sleep is important. That's a wrap for our discussion today. We've got one more episode coming, so stick to your podcast feed. And be sure to watch our case series on iTunes under the series title, The Good, the Bad, and the Frustrating.